This is an interesting case involving a patient who underwent elective transcatheter closure of patent foramen ovale and subsequently developed life-threatening hemorrhage, which fortunately self-resolved. This case teaches us a few important points regarding peri-procedural care. So transcatheter closure of patent foramen ovale is routinely recommended in patients less than 60 years old for secondary prevention of cryptogenic stroke when PFO is thought to be the most likely cause of the stroke. However, in elderly patients such as this one, the decision is often arrived at by shared decision-making conversation with the physician, as there is less evidence for this procedure's efficacy. Our case involves a 72-year-old male, otherwise previously active and healthy, likes to golf. He does have a medical history of benign prostatic hyperplasia, vestibular migraines, and recent COVID infection, who presented with sudden right arm weakness and expressive aphasia. He was diagnosed with TIA, as symptoms fortunately resolved, and he was started on dual antiplatelet therapy as well as statin. Upon further conversation with his physician, he decided to undergo PFO closure, as echo with bubble did demonstrate a PFO. The next month, he went for the elective procedure and all went successfully. However, in the post-operative period, he needed to void his bladder and he was required to lay supine. So he needed to strain in order to urinate. And upon straining, he suddenly felt unwell. His blood pressure was found to be 51/31 with a map of 42, and the patient was experiencing lightheadedness. Immediate CT abdomen and pelvis showed a large retroperitoneal hemorrhage extending into the right upper quadrant, likely from mesenteric venous injury. Stat vascular surgery consult resulted in them deeming the patient too high risk, and they opted for conservative management with reversal of heparin using protamine, as well as massive transfusion protocol and fluid support. Patient did eventually make a full recovery, fortunately. However, he did require 5 days in the ICU. Overall, transcatheter closure of PFO is usually safe. However, it can result in rare vascular complications such as occurred in our patient. The mechanism of injury of our patient is unclear, although we hypothesize that it may have been caused, or at least in part owed to the increased intra-abdominal pressure with straining to void the bladder. So peri-procedural precautions are very important, and it is probably wise to encourage Foley catheter use, stool softeners, laxatives, antitussives, as well as adjustable bed positioning in order to avoid increasing intra-abdominal pressure in the immediate post-operative period for transcatheter procedures, especially in the elderly who are prone to vascular injury.